Good afternoon, and thank you for joining us for Chats with the Chief, a Belonging Dialogue. And my name is Duane Reynolds, and I'm the founder and CEO of Just Health Collective. And we're a professional services firm that is focused on accelerating health equity and belonging in health and healthcare organizations. So if you're so inclined, if you would please feel free to click share at the bottom of your screen. Would love to have any of your network join in on this particular conversation so that they can certainly benefit from hearing from those leaders who are discussing the topics that we cover. So we'll leave time to answer your questions. So feel free to post them as they come to you into the chat, and we'll be excited to take some time to answer those questions. So today's conversation is focused on diversity and healthcare policy. While most healthcare organizations are actively developing new ways to connect with patients, families, and communities, they have to begin to do so by recognizing the historical, the institutional, and the system factors that work against advancing health equity and belonging in healthcare. So I'd like to introduce you to today's guest, who is an esteemed alum of The Ohio State University, Amy Rohling McGee. And Amy has served as the president of the Health Policy Institute of Ohio, which is a nonpartisan independent nonprofit organization that provides information and analysis to state policymakers since 2010. She's a passionate leader dedicated to improved population health, sustainable healthcare spending, and equitable outcomes. Amy has more than 20 years of experience in management, government relations, policy development, strategic planning, stakeholder engagement, coalition building, communication, and quality improvement. Her prior public sector experience includes working in the executive branch of state government, focused on policy-related issues such as health insurance, health system improvement, and Medicaid, and service in the state legislature as a Legislative Service Commission intern from the mid-1990s. Amy's private sector experience includes 5 years as the executive director of the Ohio Association of Free Clinics, representing health clinics that served the uninsured primarily through volunteers. So now I'd like to give a great welcome to my friend, Amy.
Thanks, Duane, and congratulations on the 1-year anniversary of the Just Health Collective.
Thank you so much. We are about at 1.5 years, but we hadn't taken the time to really stop and just celebrate the moment of passing that 1-year anniversary as a company. So we are excited to be where we are, and I appreciate you recognizing that. So, Amy, I have a few questions for you, but the first, if you could just tell us a little bit about the mission of the Health Policy Institute of Ohio and, who the organization serves.
Well, our mission is to be an independent and nonpartisan voice and to provide analysis to our state's policymakers and to others who are influencing the policymaking process, so that the kind of policies that we're enacting in our state are evidence informed. We were created back in 2003 by a number of foundations from throughout the state of Ohio, and those remain our steadfast supporters and investors.
Excellent. Well, Amy, I have a little bit of work going on in the background. So what I'm going to do is pass the question along, and then I'll put myself on mute just to make sure we can hear your answer, which is the most important part. So I want to dive into the Health Policy Institute's Health Value Dashboard. First, can you give us an explanation of what that product is?
Well, it's a collection of metrics, and we're focused on measuring how we're doing in our state in terms of health overall, and how we're doing in terms of healthcare spending. So back now, it's been about 8-9 years ago, we brought together a group of experts here in Ohio, and we said, well, what is it that we can all come together around? What do we all care about, regardless of whether we're in the public sector or the private sector, whether we're in a healthcare provider setting or a health insurance company or an advocacy organization. And we ended up identifying that we all cared about improving health and we all cared about sustainable healthcare spending. So what we call health value is the intersection of those two areas. We want improved health value for people in our state. We know that we had a sense, even before we collected the data, that we weren't doing well in terms of health. And we also knew that sustainable healthcare spending was a concern for businesses, employers who are purchasing health insurance for their employees. We knew it was a concern for taxpayers who are funding programs like Medicare and Medicaid. We knew it was a concern for consumers who are having to pay more and more out of pocket for their healthcare expenses. So we wanted to look at that data as comprehensively as possible, but also in a succinct way, because we know that there's many, many metrics that exist. So we wanted to elevate those outcomes that are most important to be paying attention to. So thinking about that as the end goal, we also acknowledge that there was wide appreciation for the fact that there are multiple factors that influence our health, that impact our health, and that actually clinical care, that is, the care we get when we're sick or when we have a chronic health condition, that only is estimated to make up about 20% of our overall health. Most of our health is influenced by the places where we work, live, play, etc. And that we needed to be paying attention to what's happening in those environments as well, in order to know whether we have a likelihood to improve on health and healthcare spending. And then last, we know that our behaviors make a difference too. Now, our behaviors are either supported or inhibited by the environments in which we live. But we do make choices on a daily basis regarding our health, and we needed to look at measures or metrics associated with those as well. So that's what's in the dashboard. It was a consensus-based process to select the metrics, and then we're now on the 4th iteration of the health value dashboard. We're producing it every 2 years, so that our policymakers and others in our state can use it to take stock in whether we're moving in the right direction towards health value and how we compare to other states and the District of Columbia as well.
Great. So talk to me a little bit. Policymakers are obviously using this. What other types of organizations could actually make use of the value dashboard?
Really, and anyone who cares about improving health and cares about sustainable healthcare spending can use it. And we know that there are many groups, organizations that have utilized the dashboard over the last several years. Many times it's been used internally to explain to employees in an organization why certain things are being done in that organization, why, if there's organizational changes that are happening or new data that needs to be collected or new processes that need to be implemented, to show kind of what the big picture is, what it is that all of that is moving towards. We also know that many in the public and private sector have used the dashboard in their own advocacy and policy work too. So to inform the conversations that they're having with policymakers as well.
Excellent. I know it's a pretty unique tool with some great visualization. Can you share with us how was it developed and who was at the table during that process? Because I'm sure that this tool actually is something that a lot of other states and organizations, would want to create something similar to.
Mm-hmm. Well, and that is, we collect all of the data that's in the dashboard for all 50 states in the District of Columbia. Because if we're going to compare Ohio to those other states, we need to have all of that data. So we could produce dashboards for other states. But what we found to be very useful was the process that led up to the dashboard. So bringing together that group of experts from different sectors, so from hospitals, from health insurance companies, from various state agencies, to decide collectively what metrics do we want to include in the dashboard. And we actually, especially the first time we produced the dashboard, we had a lot of vigorous debate about certain pieces of data. And there were people who really were kind of advocating for a particular metric to be included. There were often people who thought that certain data was available, but it's not available consistently. And what that brings up for me too is just to mention that all of the data in the dashboard comes from publicly available sources. So that was a key criteria that we made a part of the dashboard, is that we didn't want to spend additional resources procuring new data sets. We wanted to make sure that the data was available for at least most of the 50 states. And we wanted to make sure that it would be consistently available over time, because we wanted to do this every 2 years going forward. So, sometimes there's data that was collected for a particular research study, or maybe just for a particular report. And people would have that recollection in their mind that, oh, I know I saw that somewhere. And that, it's entirely possible that it was available at one point, but it needs to be available consistently over time in order for it to be included in our dashboard.
Okay. What are some of the health equity metrics that tie into your dashboard?
Well, and I want to mention also that there are lots of other dashboards and scorecards that exist. So folks on today might be familiar with the Commonwealth Fund scorecard or America's Health Rankings, just to name a couple. And what we wanted to do in the dashboard was to comprehensively look at health and all the factors that influence health. So that included the healthcare spending dynamic, which is often not included in other dashboards and scorecards. But then we also wanted to look at equity, which is included in some other products, but not all other products. And by that, I mean, we wanted to disaggregate data where that data was disaggregatable by race and ethnicity, by income or education, and by disability status, so that we could see where the challenges lie and where we have disparate impacts for certain populations of Ohioans versus others. So we now have a series of equity profiles in the dashboard where we look in very fine detail at those specific metrics. Just to share one example from the dashboard, 1 in 10 Black children in Ohio is treated unfairly due to their race, and that is 17 times higher than the rate for white children. So we just very much wanted to elevate those kind of factors, and the fact that our systems and our policies and our beliefs unfairly favor some Ohioans over others, and that we have an unlevel playing field that we need to address through policy change.
Very good. I have a little bit of background noise going on, but hopefully you can hear my question.
Oh, sure, I can hear you. I can hear you very well. It's not distracting.
As a follow-up, how do organizations begin to understand the implication of policy and its connection to health equity? So how does your dashboard understand which potential policy considerations are actually going to be impactful in equity?
Well, we often turn to other resources to guide our work. There are a number of other tools that exist that have looked at the entire body of evidence and elevated some strategies as being those that could most impact equitable outcomes or achieve equitable outcomes. So one that comes to mind is What Works for Health. And you can find these resources simply by searching for them. What Works for Health does an excellent job of elevating strategies that are um, likely to lead to more equitable outcomes. Also, the CDC has a couple of tools. There's the Community Guide and there's High Five, and both of those tools also elevate key strategies for equity. It's worth noting, though, that even strategies that specifically haven't been rated in terms of their potential to contribute to equitable outcomes could still do so if they were implemented in a way where they were targeted toward a specific population or tailored for a specific population. So, it's important to always use that lens too when evaluating potential policy strategies.
Thank you. I appreciate that. A lot of the organizations that we work with will oftentimes not think about how policy considerations, legislations that's being proposed in other industries, for instance, transportation or agriculture, don't always see the connection into health. And so part of what we're trying to do is help them understand that not only do you have to be concerned about the healthcare industry when it comes to policy, but other components, other industries, because they ultimately impact what you were referring to earlier, the places we live, play, work, grow, which are the social determinants of health.
Right, exactly.
Yeah. So, I think a lot of institutions are trying to figure out, well, what do I need to be concerned about? And then the people within those institutions are also sort of trying to figure out, well, what can I do as an individual to advocate for health equity policy change? So, or any type of health policy change. Can you give some advice on, particularly as an individual, what should I be concerned about that ultimately may have downstream impact on health?
Yes, and that is it's a big challenge because there are the world of health policy, even if you just looked at it in terms of just what happens in healthcare settings or public health settings, there's still a lot that goes into just those settings alone. And then when you broaden to think about all the social drivers of health, it's basically everything. Everything is health policy, and it is. So I think that focusing perhaps on an outcome that you care about might make sense. So I'll just use an example. Maybe it's something related to, like, maybe you care about our adult smoking rate or youth exposed to secondhand smoke. And that's the outcome that you're concerned about. So thinking then about, well, what are all the factors that contribute to that? Well, one, it's an addictive substance. And we know people need additional helps and supports for overcoming addiction. So what can we advocate for that would make sure that everyone has access to those supports, whether it be tobacco cessation counseling or medications to help people overcome that addiction. But then it's also thinking about the systems and environments in which people live too. And there's issues related to targeted advertising, especially towards people of color. And this is one of the reasons why there's high rates of smoking in the Black population. That you could also look at issues related to stressors. and why people smoke in the first place, why they start smoking in the first place, and addressing some of those root cause issues. And it's like once you begin to pull apart all of the factors that are contributing, then you can kind of trace back to policies and what could be policy fixers or levers to address some of those root causes. But I find it useful to kind of start at the issue you want to impact, and then to begin to fully educate yourself about all the ways in which our systems and environments influence that outcome, and get involved that way.
That's a great explanation. It really then is figuring out what the root cause drivers are that are impacting health downstream.
Exactly.
And to your point, really, it's everything has the potential to impact health, but sort of following those factors back, and then considering how you vote and whom you vote for matters in this process. And I also want to point out that policy really has the ability to impact systemic change, which now we understand systemic racism's impact. There may have been policies in the past, or even policies that are being proposed today, that can have a continued systemic impact on different demographic populations.
Well, and and to take it, so there's of course individual level advocacy that people can get involved in. Our elected officials are there to serve us, and they want to serve us, and they need to hear from us too. So always knowing who your elected officials are, who represents you in your state, whether it be your state house, your general assembly, whatever it's called in your state, who represents you in your city council, who represents you in the Congress or the U.S. Senate, and and then also knowing what kind of policies are made at the local level, the state level, and the federal level is important too, so that you can direct your concerns to the appropriate body. So there's all kinds of potential there to weigh in on key issues, and there's all kinds of organizations that you can get involved in too, who are paying close attention to these issues. So going back to the tobacco example, you can get involved with the American Cancer Society or some other tobacco control group, and sign up to get alerts or notifications when they really need people to mobilize and make their voice heard on a particular policy change. Now, I know that you have a lot of organizational members too, and I think there's opportunities for those organizations to get involved as well in policy change. Sometimes that can be through partnerships and collaboration with others. So hospitals can partner with other, say, affordable housing related organizations in a community, and work together to address issues related to, say, safety in housing, like whether there's lead exposures in houses, or other toxins in housing, and address those together. And it's that kind of collective approach, it is much more likely to impact lasting change than any one of us acting alone.
Yeah, that is a really great point. And a lot of times, healthcare organizations now are thinking about these partnerships and ways that they can get involved with partnerships, and who are the organizations that they should be seeking to be involved with. But, you make a great point that policy is one way that you can begin to impact health through collaboration with these organizations. So I appreciate that. I want to mention to our audience, if you have a question for Amy or myself, if you'd type that into the chat, we will be certain to answer that question for you. So Amy, what's on the horizon for your organization? What are the major things that you are concerned about as you think about how your organization, again, impacts health equity.
Well, one issue that we have been focused on quite intently is on adversity in childhood. And this is something, well, I referenced the example from the dashboard related to exposure to racism a little bit ago. But even beyond that, we've done a series of briefs related to adverse childhood experiences, with one just released yesterday, where we elevated 12 potential policy changes that could impact adversity in childhood. We know that exposure to trauma and toxic stress can have a lasting impact on health over the whole entire lifespan, not just in childhood. And we know that there's widespread agreement and a commonly held value that all children deserve a fair start in life. So we're hopeful that there is some consensus around that, and we can make some progress on the kinds of policy changes that we elevated in that most recent brief. We're also continuing to work diligently on topics related to equity, and moving forward the kinds of policies and strategies that we elevated in the dashboard as well. We have we have a new fact sheet coming out here shortly that'll dive deeper into what state and local governments can do to advance equity. While we do write for an Ohio specific audience, any of the insights in these briefs that I'm mentioning they're relevant to other states as well. So I would encourage folks to maybe sign up for our email alerts so that you can get those kinds of documents when they come out. And our email or our website is hpio.net. So all of these reports are publicly available.
Excellent. So just make sure everybody heard that, hpio.net. And you can sign up for the newsletter to get policy alerts for things that you should be considering as we think about improving health overall. And it doesn't look like we have any questions in the chat. So Amy, I have been very excited about this conversation, and you did not disappoint at all. Thank you for bringing us great information for us to consider as we think about how we ultimately impact health and health equity in general. And I really appreciate your time being on the show. And again, for those of you that are interested in this type of work, please visit hpio.net. Amy, thank you so much. And certainly go Bucks.
Yeah. Go Bucks.
Yes, and I have a few members of my team that have gone to other schools that shall remain unnamed. But I always like to reference the Ohio State University, and I'm so pleased to have an alum on the show with me, and just thank you all for all that you are doing in the state of Ohio and in your work in policy.
Well, and I'm very glad that our paths crossed through our work on the Alumni Association Advisory Committee, and very much appreciate the invitation to be with you this afternoon.
Thank you so much, and have a great rest of your day.
Thanks. You too.
Bye.
Bye.